clinical examination of the musculoskeletal system. Examination of the hip joint is performed when a patient is lying and standing. The anatomy of the hip joint does not allow direct inspection and palpation in other joints, so movements are more important in assessing hip pathology. The affected hip should be adequately exposed, so undress to the underwear and pull down underwear to see the iliac crest, and compare with the opposite hip. With the patient standing, observe from the front and note the stance, straight or not, and shoulders, are they parallel to the ground, pelvic tilt and deformities. So from the side, look out for a stoop or lumbar lordosis. This may result from a flexion contracture. From behind, you look out for gluteal atrophy. Know the muscle bulk and position of the hip joint. Inspect the nail and skin for evidence of psoriasis, and also inspect the sole of the feet for evidence of keratoderma blenoragica. Inspect the skin for erythema nodosum, and inspect the joints for osteoarthritis. Also inspect the feet, ankle and knees for important clues to the underlying pathology in the affected hip joint, and also compare the muscle bulk in the thighs and pelvic girdles. Wasting of the muscles is common in arthritis of the hip joint, and in fracture of the hip there is severe swelling in affected hip with or without reason. Do not any shortening or deformity. Shortening, adduction and external rotation of a deformed hip is seen in fracture of neck or femur and severe arthritis of the hip joint. So measure the leg length and assess any fixed flexion deformity. Using a tape, measure the distance from the anterior superior iliac spine to the medial malleolus on the same leg. And locating the anterior superior iliac spine is not easy in obese subjects. The apparent shortening of a limb, but with normal measurement when compared to the other limb, is seen in adductor muscle spasms associated with weakness in adduction of the hip, leading to tilting of the pelvis and scoliosis of the spine. The true shortening is seen in severe disease of hip or knee joint, resulting in collapse and loss of bone. The congenital shortening can also occur. And now you palpate the hip joint, anterior triangle of the thigh for any tenderness or fluctuation denoting an effusion. Now you test the range of movement actively and passively with the hip and knee at 90 degrees, testing for rotation, adduction and abduction of the hip. So the range of passive flexion is slightly higher than active movement. In testing rotation of the hip, we use the heel as the point of reference. So external rotation of the heel will result in internal rotation of the hip, and external rotation of the heel will result in external rotation of the hip. Now you assess the pelvis for the range of movement. You place the hand on the anterior superior iliac spine and feel for tilting of the pelvis as one test for adduction and abduction of the hip joint. In normal subjects, the pelvis does not tilt. In disease of the hip joint, the pelvis tilts down on abduction and tilts upwards on adduction. Normally, active examination of the hips is painless. Limitation of rotation and extension of the hip joints. With the patient prone, will detect early signs of hip arthritis or synovitis. Be aware of crepitus of the hip joints felt by the examining hand, which indicates mechanical damage or osteoarthritis. If no pathology is detected after examining the hip joints, then the cause may be referred pain from spine or soft tissue swelling or bursitis of trochanteric region. Greater trochanter has a small anterior bursa and a large inferior bursa, and inflammation of these can lead to pain. Antisopty at the insertion of the gluteal muscles can cause pain. Antisopathy is a disorder of the muscular and tendinous attachment to bone. Ischial bursitis and adductor tendinitis are other causes of pain arising from the soft tissue. Examine the hernia orifices in the absence of hip pathology, and also look for entrapment of the lateral cutaneous nerve of the thigh, leading to pain in the lateral side of the thigh. Examine for sensation in the distribution of the nerve, and examine the abdomen, especially the renal angles, which may give rise to referred pain in the groin on weight bearing. And then let the patient stand and observe the gait while he's bearing weight on the affected limb. And examine the patient from the posterior aspect and observe the horizontal creases on the lower side of the trunk for assessments of the position of the pelvis. In the normal subjects, when weight is borne on the right hip, the pelvis tilts upwards to the left to allow the left leg to swing through the arc. In diseased hip with adductor spasm and weakness of the adductors, the pelvis is tilted downwards on the diseased side when the patient bears weight on the diseased hip. This is the Trendelenburg sign, which leads to waddling gaits, which demonstrate failure of the pelvis to tilt upwards to the opposite side when the patient bears weight on one hip, and the pelvis remains the same and tilts down on the affected side, whichever leg it bears weight on.